Hi everyone, this is Scott Reeves and this is Lipid Lecture 3 of FSN 328, and this lecture starts off talking about atherosclerosis, and we'll learn kind of a description of it, and then we'll go through the steps of atherosclerosis. We'll talk about the risk factors real quick, and then one of the things that is interesting about this lecture is it's kind of where the diet can affect lipoprotein metabolism and how that can affect atherosclerosis. So that'll be towards the end of this lecture where we'll talk about effects of the diet in this process. So first of all, atherosclerosis is part of heart disease, and heart disease is the most probably significant chronic and lethal disease in the Western world, and so it's extremely prevalent. And the description of atherosclerosis is it involves the accumulation of cholesterol in the arteries, the narrowing of the arteries, and the formation of abnormal surfaces on the luminal surface of the arteries. So it's accumulation of cholesterol in the arteries, the narrowing of the arteries, and the formation of abnormal surfaces on the luminal surface of the arteries. And when that happens, the narrowing of the arteries can result in cardiovascular disease, and it can occur in arteries outside the heart, but it is generally a lot more problematic when it is around the heart. That can lead to, obviously, lethal heart attacks. Now, the main factors in this process are cells of the immune system and lipid material, which is mostly cholesterol and cholesterol esters. So what are the main risk factors for this? Well, there are a few of them. Genetics, of course, is an important risk factor in a lot of diseases, including this. And being male, we tend to have a little bit more susceptible to heart disease than females. Cigarette smoking significantly increases the risk of atherosclerosis. So does high blood pressure, obesity, and a sedentary lifestyle. So one of the things to keep in mind about atherosclerosis is it is multifactorial. There are several different factors that are involved in determining whether or not a person has atherosclerosis. It doesn't mean if you have any of these you will get it. It just means it increases the risk. The biochemical risk factors, we can list these. We can say it's high plasma LDL cholesterol, low plasma or blood HDL cholesterol, high plasma triglycerides, and diabetes can increase the risk of heart disease. And one of the reasons is because it tends to increase blood lipids. Okay, so let's start going through this. Now, this is the latest theory on atherosclerosis is what's called the response to injury theory. And cells within the coronary artery are injured, and then the causes of injury can include things like, so these are the three most likely causes: hyperlipidemia, most of the time, so that's high blood lipid, most of the time that's high cholesterol; smoking; and hypertension or high blood pressure. Those can all damage the artery, and that can then cause a response from the cells of the immune system. And then lipid materials can become involved in this significantly. So one of the other items that goes along with this lecture and your assignment is an article that I got from Scientific American a few years ago. And so I would look through that, and especially the graphics. The graphics in this are excellent, and it also has kind of a step-by-step of the five steps in the process. So you can look at the graphics, and then each graphic, it has a brief description on what's going on there. So I would suggest going through that. It's also helpful for some of the terms and definitions and even the spelling of those terms. Okay, so I'm going to use that article as kind of the basis of this, and I'll simplify it. And we're going to start looking at these in steps. And so let's start looking at step number 1. And if you can look up at the top, we have the first 3 steps. The first one is the injury. Step 2 is macrophage accumulation, and the third step is the fatty streak formation. So I'm going to go through and briefly identify each of those. So you would want to know the name of the step and the parts of that step. And a good way to look at this is figuring out and remembering how one step leads to the next. Okay, so if we look at this graphic here, we're looking at a coronary artery. And if we look in a closer detail of that, we see that the coronary artery is surrounded by what's called the adventitia. And then there is the media or media. And then the innermost part is called the intima. So we're going to talk about details of the intima. And then the opening or the blood channel where the blood is actually flowing through. And if you look over on kind of the right side of this, you can see different cell types moving through this blood vessel. We can see red blood cells, which are the most common type of blood cell. And then we see some of these other ones that are part of the, they're white blood cells, part of the immune system that travel through here. Now, if we look down here towards the right part of this cross-section of an artery, we can see steps 1, 2, and 3. So we're going to talk about that process in more detail because that coincides with the steps of injury, macrophage accumulation, and fatty streak formation. But one of the things to notice is there are molecules, some of these cells and molecules can actually enter into the coronary arterial wall. It used to be when they first started figuring out atherosclerosis and heart disease, they thought it was simply lipids accumulating on the surface of the arterial wall. And then they started getting evidence that that wasn't the case. It was actually cells and material accumulating within the arterial wall. And as those accumulate, they accumulate to the point where it builds up and can eventually block this artery. Or in some cases, it actually causes a clot. So we're going to talk about that. If we look at this kind of inset here, we can talk about steps 1 through 3 in this process. So if we look at step 1, and let's just identify some of the molecules here. Here we have LDL. These cells along here, see this is the actual wall or surface of the artery. These are called endothelial cells, and it's labeled right here. So make sure you remember that. Endothelial cells, not epi, endo. And we can see, for example, adhesion molecules here, these extensions, and we see a couple different cell types. We have monocytes, which are part of the immune system. We have T cells. And you can see the monocyte is actually bound to this adhesion molecule, and then the monocyte can actually kind of roll in between the endothelial cells to get into this intima. Okay, so let's talk about step 1. Step 1 is the injury to the coronary artery, and the injury occurs to the endothelial cells and or its underlying tissue. Most common sources of injury: hyperlipidemia, which can be high cholesterol or high triglycerides, and smoking and high blood pressure. Any of those can cause these endothelial cells to be injured. Now, the injury promotes the release of chemokines. Those chemokines are signaling molecules released from endothelial cells. So the injury causes a release of chemokines, and the chemokines attract monocytes. So the monocytes are coming to the injured area. When the monocytes get there, they can bind to the adhesion molecules. Okay, so step 2 is called macrophage accumulation. This is when the monocytes are attracted by the chemokines and the monocytes bind to the adhesion molecules. The monocytes then pass between the endothelial cells and into the intima. In the intima, the chemokines cause the monocytes to convert to macrophage. Here's my cursor. See the way they're converting here? They're converting from a monocyte into a macrophage. The macrophage engulf LDL particles by an unregulated pathway, and they use the LDL receptor to do that. So you can see where the LDL here have been modified, and the LDL are now being absorbed. See, it's really hard to see this, but there's a receptor on the outside of the macrophage that is taking up the LDL particle. Now, normally that uptake of LDL by cells in the body is regulated, and normally the receptor numbers go down as cholesterol goes up inside a cell, but these are unregulated. Okay, so the macrophage continue to absorb LDL until it becomes excessive. One of the other things that the LDL has makes them more likely to be taken up by macrophage are modified LDL. So macrophage tend to target modified LDL. And there's two main types of modifications. One is oxidized LDL. And a common source of oxidizing LDL is from cigarette smoke. The other modification tends to be glycation, and that's when carbohydrate are bound to the LDL protein or the LDL lipids. Those are called glycated LDL, and that can occur when a person has, long-term high blood glucose. Those LDL are likely to be bound to carbohydrate, and those macrophages tend to look for those LDL. Okay, so now the macrophage has accumulated LDL. Step number 3 is when a fatty streak forms. That's the accumulation of lipids by macrophages causes the macrophage to become foam cells. So foam cells are macrophages that have accumulated too much lipid, and the cells become dysfunctional. Okay? That process perpetuates or continues until a fatty streak is formed. So this is an actual visible bulge. Where if you look over here, these foam cells are now trapped in this intima. They're not going anywhere. And if you look over here, what's happening is they're starting to accumulate to the level that they're pushing out the arterial wall into the opening of the artery, so it's starting to block off. Step 3 is plaque progression. So these areas here that have accumulated a lot of lipids and dead cells are called plaques. When that happens and plaques start accumulating, these cells in this plaque are releasing chemokines that's causing causing the smooth muscle cells to migrate. So this plaque, these cells are releasing molecules that cause the muscle cells to go to the top of this bulge. Those muscle cells are essentially trying to close off that injured area. Now, now these smooth muscle cells begin synthesizing collagen, and collagen is a fibrous protein that's part of the plaque. Okay, so the muscle cells are making collagen so that they can hold to each other. And this process can repeat until blockage of the artery occurs. Okay, so we have smooth muscle cells blocking this off. Okay, now if that blocks off blood flow, that can cause a part of the heart to become necrotic or die, and that's a heart attack essentially. Now that only happens about 15 or 20% of the time. In other words, most of the time that's not what causes a heart attack. Step 5 is more common. Now, step 5 is plaque rupture. That's where some of the cells in this tissue are secreting collagenase. That's an enzyme that degrades collagen, and the plaque may rupture because of that. So in other words, these cells start releasing collagenase, and it breaks the collagen in between these muscle cells, and that causes the actual tissue to have a gap. And when that breaks, cells from under here are exposed to platelets. And so if this occurs, a clot can form. So these are platelet cells right here, and a thrombus means a clot. So plaque rupture leads to clotting, and the clot can remain on site and block the blood flow, and that can cause a heart attack, or the clot can dislodge and block blood flow elsewhere in the body. And if that happens, essentially you have a traveling clot or a thrombus that goes to the brain, that can cause a stroke. And if say for example, it's in a kidney cell, that can cause, or a lung, it can cause a clot that can cause an embolism and significant damage or failure to that tissue. So a lot of times it can start in the heart and then move to other parts of the body, and that's what actually happens most of the time in a heart attack or a stroke, is when that plaque actually ruptures. Okay, and if you look down here, this lower part of this actually shows this, and even over here we can see that fatty streak and then the actual rupture. Okay, so there's a few ways to diagnose this. You can do imaging studies now where they're actually looking for it, but a lot of times they don't know this is occurring until something drastic happens. Okay, now one of the things that is involved in this is LDL. And in general, the more LDL cholesterol a person has, the more likely this is going to be occurring in their arteries. And of course, the other thing, as I mentioned, is the immune system. They're both important. So the worst scenario is high blood LDL cholesterol with chronic inflammation. And that can increase the risk of all of this happening because your immune system has been already triggered. And there's other ways that it can be triggered. And then if you have LDL cholesterol on top of that, then that kind of increases two significant risk factors for this. Okay, so that's the basis of the process. So now let's start looking at a little bit have to do with diet. So diet, lipoproteins, and the risk of cardiovascular disease. Therapy has been based on the goals of reducing the concentration of LDL cholesterol and actually increasing that of HDL cholesterol in the plasma. Because if you have higher HDL cholesterol, it can actually help move cholesterol to the liver for excretion. So again, we want low LDL and high HDL to be protective. So reduction of LDL cholesterol is expected to limit the uptake of cholesterol by cells in the fatty streaks. An increase in HDL cholesterol is considered to be of value because its presence indicates an increased rate of removal of cholesterol from the walls of arteries. Okay, so what about dietary fats? Well, the role of dietary fats and cholesterol is still considered to be kind of a cornerstone of, well, dietary fats and cholesterol can affect cardiovascular development by modulating plasma lipoprotein concentrations. Okay, dietary modifications remains the cornerstone of cardiovascular disease prevention. It should, right? We want it to be part of a person's healthy lifestyle, is for them to increase healthy nutrient dietary intake. So it is estimated that every 10% increase in LDL cholesterol increases the risk of cardiovascular disease by 20 to 30%. So it's important to control LDL cholesterol levels. Now, the average U.S. diet contains about 34 to 38% of calories from fats. And in general, that's too high, but it's both the amount and type of the fats that affect plasma lipoproteins. Okay, we've probably all heard that. But one thing to keep in mind, and we're not going to go through these specifically, but if a person consumes even a couple thousand calories a day, and let's say 35% of it is from fat, even over a year you'd consume something like 50 to 70 pounds of fat. And all of that fat is basically moving through your digestive system, your absorption, going into your tissues and affecting what happens in the body. So it's important that we control the amount of fat intake, but also the type of fat. Now, I'm not promoting a low-fat diet, but it should be probably moderate levels of fat and good types of fat. We're going to go through that in 1 second. Okay? Dietary saturated fat. Now, this is data from studies that I trust. This is still relatively controversial. Every few years, controversy comes up when a new study comes out that says saturated fat's not a problem. We're not prepared to say that yet. I think we should still be aware that saturated fat can be a problem. But in general, saturated fatty acids tend to increase plasma LDL cholesterol. So that's what I'd like you to remember. They tend to increase plasma LDL cholesterol. The average U.S. saturated fatty acid intake is 12% of energy, right? And it should be less than that. Now, of the saturated fatty acids, palmitic acid, which is the C16-0, is the major saturated fatty acid in most diets. So as far as amounts, palmitic tends to be the most significant, then stearic, then myristic, and then lauric. Here's the problem. Palmitic and myristic fatty acids have the greatest LDL cholesterol raising potential. So the two that tend to be the most problematic are pretty high in our diets if you're eating saturated fat. Now, how does this work? Well, saturated fatty acids decrease LDL receptor mediated endocytosis by decreasing LDL receptors at the plasma membrane. So if they're decreasing LDL receptors on cells, that means more LDL stays in the blood. And that increases the likelihood that that LDL might be modified and then become part of atherosclerosis. Okay? So that's one of the major mechanisms. However, stearic acid does not increase LDL cholesterol, and one of the main reasons is stearic can become oleic acid. So that's an exception to saturated fatty acid being harmful. Okay? What about trans fatty acids? We've heard that trans fatty acids are not healthy, and one of the main reasons is because of their effect on lipoprotein metabolism. Okay, and I mentioned this before, but oleic acid, which is a trans C18-1, is the principal trans fatty acid in the diet. And remember, that's some trans fatty acids occur naturally, but most trans fatty acids in the diet are from industrial hydrogenation of food oils. Overall, about 6% of our dietary fatty acids are trans fatty acids, and that's mostly oleic. Okay, so it's important that we monitor and control the intake of those. Now, this is what I'm saying based on studies that I put more trust in than some of the others. Most studies show that trans fatty acids increase LDL cholesterol. So we're going to say trans fatty acids tend to increase LDL cholesterol. Some studies have also shown they decrease HDL cholesterol. Not all studies, some studies. And that would be the worst scenario, right? Increase LDL, decreasing HDL. Okay, although effects are still controversial, reducing their amounts is unanimous. I mean, I don't think anybody's saying that trans fatty acids are good for us. Okay? Monounsaturated fatty acids. Many have shown that when substituted for saturated fatty acids, monos reduce blood cholesterol. However, their effects are still controversial. Monounsaturated fatty acids tend to decrease LDL cholesterol. Their effect on HDL cholesterol is ambiguous. So we're going to say they tend to decrease LDL cholesterol, which is good. They may or may not affect HDL cholesterol. Overall, it appears monos do not decrease LDL cholesterol as much as polyunsaturated fatty acids. So the balance of fatty acids is important, right? We want to make sure we consume some monos and some polys, and we have to have some saturated fats. Okay, olive and canola oils are good sources of the monos. Oleic acid, for example, is known to increase expression of the LDL receptor, and that leads to a decrease in LDL cholesterol in the blood. So if we consume significant amounts of oleic, which is most common sources tend to be, for example, in olive oil, then that oleic acid in cells increases the expression of LDL receptors, and those LDL receptors take LDL cholesterol from the blood into the cells so that it's not harmful. Okay, and about 75% of the fatty acids in olive oil is oleic acid. So that's a good source. Canola oil is also a pretty good source of oleic acid. Okay, now what about polyunsaturated fatty acids? Polyunsaturated fatty acids can decrease LDL cholesterol. For example, linoleic acid is the main polyunsaturated fatty acid in our diet. Linoleic acid reduces both LDL and HDL cholesterol. Okay, so reducing LDL is good, decreasing HDL is bad. So what do? We don't eat too much linoleic acid. We consume some, but not relying on it exclusively, because decreasing HDL is not good. So again, balance of polys is good with monos and some saturated fat. Now, the polyunsaturated fatty acids that are omega-3s, for example, those that are high in fish oils, they tend to lower blood triglycerides, and they by doing so, they reduce the risk of cardiovascular disease. So triglycerides are another factor in this, in addition to blood cholesterol. So omega-3s can be good because of that. Some of their effects are independent of their effects on plasma lipoproteins. Remember, omega-3s reduce clotting and they lower blood pressure. Those are two major factors in cardiovascular disease. So again, the omega-3s can decrease LDL cholesterol, and they can decrease clotting, and they can lower blood pressure through the eicosanoid mechanisms. Okay, so it's important that we remember that omega-3s have a few different ways they can decrease the risk of cardiovascular disease. And what about dietary cholesterol? Most studies have shown dietary cholesterol tends to have less potent effects than saturated fatty acids. Okay, so if someone does have high blood lipids, including LDL cholesterol, they do want to watch their dietary intake of cholesterol, but they do want to take into consideration fatty acid intake, especially saturated fat. Okay, dietary cholesterol is more variable in its response than dietary fats, but dietary fats and cholesterol tend to interact. So, for example, the worst case scenario is consuming high cholesterol and consuming high amounts of saturated fatty acids. The best is reducing cholesterol intake and reducing saturated fatty acid intake. For example, saturated fatty acids reduce less than 7% of energy. Remember we said it was about 12% in general. And cholesterol to less than 200 milligrams a day. Recommended amount is less than 300. But if you do both of those, that can result in plasma cholesterol being reduced by 15 to 20%. So that is significant. The combination of those is a really good strategy. Now, why don't we just raise HDL? Well, it's not a piece of cake. It's not easy to raise HDL, and there's lots of factors involved here. But HDL is protective. One of the hypotheses, and supported by significant data, of why women tend to live a few years longer than men is because women tend to have higher HDL cholesterol, and it's protective. Okay, so there are gender differences, there's also age differences, and lots of other factors. But here are some things in general. Physical activity tends to raise HDL cholesterol. For example, 45 minutes a day at 4 times a week can raise it by about 5 milligrams per deciliter. And that might not sound like much, but 50 milligrams of HDL cholesterol per deciliter is a significant amount. So this is about a 10% change, and that can be protective. Okay, now it should be vigorous exercise. It doesn't have to be really intense, but it has to be something that actually causes a cardiovascular response. So heart rate's got to go up. It's got to be relatively intense for that to happen. Now, it depends on who's doing it, what mode of exercise, and lots of other factors, but in general, physical activity raises HDL. Also, weight loss, especially around the waist, can also help maintain or raise HDL cholesterol. One of the factors here is as a person loses weight, especially around their waist, their insulin sensitivity tends to improve, and that probably decreases decreases cholesterol synthesis, and that would decrease LDL cholesterol, and that can also help maintain or raise HDL cholesterol. Okay, and then moderate consumption of alcohol has also been shown to raise HDL cholesterol, and this is moderate. This is not high amounts. Moderate is considered to be 1 drink or less for women, and 1 to 2 drinks a day for men. I'd say probably on the lower end of that is probably better, but some studies have shown. And it's not just wine, it's the actual ethanol. So wine has the ethanol benefit, and it also has some of the antioxidants that can be beneficial for lipoprotein metabolism. So with wine, you kind of have 2 different mechanisms responsible for that. Okay, so those are just some of the ways. So we're going to have physical activity, maintain a healthy weight, and then moderate consumption of alcohol. Now, the protective effect of alcohol is not considered to be significant enough to suggest a person start drinking to decrease their HDL cholesterol. But if they do, if it's done in moderation, it can be fine to do so. Okay, so that's the end of Lipid Lecture 3. and we'll discuss this in class for any questions.